All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's episode is going to be on a foundational topic in medicine, and that is distributive shock. In this episode, we're going to be talking about what distributive shock is, key features, classic presentation, pathophysiology, hemodynamics, oxygen consumption, subtypes of distributive shock, management principles, some landmark trials, practice questions, and much more. So no further ado, let's dive in. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. So starting with what distributive shock is. Well, distributive shock is a type of shock caused by the loss of vascular tone. And this loss of vascular tone can lead to some degree of maldistribution of blood flow. And what that means is when you have blood vessels, let's just go with the veins, okay? Let's say this is the quote-unquote classical amount of vasodilation. In distributive shock, you lose vascular tone. Okay, you get vasodilation. These veins dilate, and I'll just say they're this size. What that means is the amount of blood flow in this vein is now accompanying a larger space because of the vasodilation. And this gets into another concept called stressed and unstressed volume, which maybe we'll dive into in a future episode, let us know. But what this means in distributive shock is the loss of vascular tone leads to this maldistribution of blood flow where you have more unstressed blood flow, right? You have more unstressed volume. You have a similar amount of volume in vasodilated blood vessels, and that leads to impaired tissue perfusion because you have less relative volume going through these vasodilated blood vessels to try to perfuse the tissues. So you get some degree of impaired tissue perfusion. And this is despite adequate or even increased cardiac output. So your heart is pumping away, right? Your cardiac output, the amount of blood being pumped out of your heart, is adequate or even increased compared to your baseline. But because you're so vasodilated, you've lost your vascular tone. There's not enough effective or stressed volume in your blood vessels to perfuse your tissues adequately. And the key features of distributive shock, the hallmark features, are decreased systemic vascular resistance, right? That's vasodilation or that loss of vascular tone, okay? So you get decreased SVR. And in the early stages, as we talked about, your cardiac output usually is preserved or even increased, right? Your contractility, you're often hyperdynamic, that heart's squeezing away. As distributive shock worsens, though, in the later stages, your heart can only handle that type of stress and hyperactivity for so long. So eventually you might actually start to get some myocardial depression or, quote unquote exhaustion, some myocardial injury from kind of that hyperdynamic increased contractility workload, and that may lead to a decrease in your cardiac output in later stages of distributive shock. But in the early stages, you have increased cardiac output and decreased systemic vascular resistance. And we're going to get into both of these things more as this episode goes on here. People often describe distributive shock as this relative hypovolemia. And we've mentioned this a couple times in this episode already because we think it's really important. The amount of circulating blood volume is normal in distributive shock. Okay? It's not like you've been hemorrhaging blood or that you're super quote-unquote dehydrated. Now, you could be hemorrhaging blood or dehydrated and also have distributive shock, but that's not part of the innate pathodrome of distributive shock. The circulating blood volume is actually normal, but that circulating blood volume can be thought of as kind of ineffective or relatively hypovolemic because that vascular compartment in general is all vasodilated. So you have less stressed volume, you have less effective circulating volume, because that volume's the same, but that vascular compartment is all vasodilated. So the effective amount of volume is less, despite the total volume being the same. Hopefully that makes sense. And again, we're going to go through it more as this episode goes on. So if it doesn't make sense now, hopefully it'll fall into place as things continue. The most common cause of distributive shock, and one we've talked about on this channel many times, is septic shock, right? This is a distributive shock from an infection when your immune system goes all haywire and causes lots of inflammation throughout the body, leading to distributive shock. And again, we'll get more into that as the video goes on here. So the classic presentation of distributive shock, well, starting with vital signs. Someone walks into the emergency department or comes up to the ICU or goes to the medical floor, and vital sign derangements in distributive shock include what you see in all shock states: hypotension. Now, we have talked about shock in general, and shock has a formal definition, which often involves hypotension, but pathophysiologically, you do not have to be hypotensive to be in distributive shock. Shock in general is inadequate oxygen delivery to tissues on a systemic level. Okay, so you can be normotensive and still be in shock. Although for the formal definition, the one people talk about, hypotension or a MAP less than 65 is often something people discuss. But just know, you do not have to be hypotensive to be in shock, including distributive shock. All right, often you have a widened pulse pressure. So what is pulse pressure? Pulse pressure is the systolic blood pressure minus the diastolic blood pressure. And in distributive shock, the diastolic blood pressure is often very low because of that decreased systemic vascular resistance, aka that vasodilation. And as such, you usually have a widened pulse pressure. You know, someone might be 110 over 30 millimeters of mercury, right? That widened pulse pressure, that diastolic blood pressure is much lower than it should be because of that decrease in systemic vascular resistance. So you walk into a room and a patient's hypotensive, they have a widened pulse pressure and a low diastolic blood pressure. That might indicate that they might be in distributive shock compared to other shock states. Certainly not specific, right? There's lots of different things that can lead to widened pulse pressures, but this is one of those things. And most often patients are tachycardic. So they're most often hypotensive tachycardic with a widened pulse pressure, most evident by a low diastolic blood pressure. Now that tachycardia, remember, if someone's on a beta blocker like metoprolol, that's going to blunt that tachycardia. If someone is in neurogenic shock, they're often bradycardia, which we'll get more into, but distributive shock in general, usually tachycardic, because you have to mobilize that increased heart rate to increase your cardiac output. We've talked about on the channel, cardiac output equals heart rate times stroke volume. We said in distributive shock in the early stages, cardiac output is increased. So how do we increase cardiac output? We increase our heart rate. That's our sympathetic compensatory drive to maintain organ perfusion. So you usually get tachycardia. So vital sign derangements classically would be hypotensive, tachycardic, widened pulse pressure with a low diastolic blood pressure. What about physical exam wise? So you've seen the vital signs and you're like, this seems like it could be a distributive shock. Well, what do you expect to see in exam? Well, early and late is how we're going to talk about this again. In early distributive shock, you're usually warm and flushed. Because of that decreased systemic vascular resistance, what that leads to is vasodilation of your cutaneous blood vessels. And that vasodilation of your cutaneous blood vessels is to warm and flushed skin. You often have bounding pulses because of that increased cardiac output, that hyperdynamic heart, that increased contractility to compensate for that low systemic vascular resistance. Usually it's to bounding pulses. And then in the early stages, if you're perfusing adequately, you might have rapid capillary refill. But you see vital signs, someone's hypotensive, tachycardic, widened pulse pressure with a low diastolic blood pressure. You walk in the room, they're warm, they're flushed, they have bounding pulses. All of that might indicate distributive shock. Now, in the late phase of distributive shock, things start to change. And this is because you can't often mobilize that high cardiac output for a prolonged period of time, or we should say indefinitely. And after a while, you can't adequately perfuse your organs. That vasodilation doesn't allow for it. And then you might actually be cool. You might have mottled extremities, poor cap refill. And that's all related to that worsening hypoperfusion that'll happen later on. Okay, so there's some kind of early and late distribution of symptoms here. So now you've seen the vitals, you've examined them, and you're like, gosh darn, this really seems like distributive shock. Are there any laboratory values that can kind of clinch the diagnosis? Well, the answer is no. But there are some laboratory values that could be somewhat indicative. Now, just know these are non-specific. Many shock states will have similar laboratory value derangements. And one is an elevated lactic acid. This is a non-specific lab marker. We should actually do an episode on lactic acids as well. Lots of things can lead to an elevated lactate. It is not specific to distributive shock, but it can be elevated with tissue hypoperfusion or tissue hypoxia that you will see in distributive shock. So an elevated lactate. And then in sepsis, this SCVO2, this is a surrogate mixed venous oxygen. We honestly probably shouldn't even put this in here. There's a very complex value and one that deserves its own lecture. But for those that are, a little more advanced in their understandings, you might see a high SCVO2 or a high SVO2, a high mixed venous in sepsis leading to distributive shock. So no specific lab values can clinch the diagnosis, although some can help you understand if you are not perfusing. All right, what about the pathophysiology? What's actually happening in distributive shock? Well, the primary deficit, as we have talked about, is going to be pathologic vasodilation, right? That decrease in systemic vascular resistance. And what is happening is you get all these inflammatory mediators that cause your blood vessels to vasodilate. And when they vasodilate, as we said, this decreases the amount of effective circulating volume, okay? Or the amount of stressed volume is another way people often talk about it. And when this goes down, we sometimes are not able to adequately perfuse our organs. As we said, our cardiac output increases to try to compensate for this. But if the SVR is so low that we cannot circulate enough effective volume, we will get inadequate tissue perfusion, secondary to that pathologic vasodilation. Now, the different subtypes of distributive shock here are important. Okay, and this is the first time we're going to talk about this. So distributive shock is an umbrella term. All right, it is an umbrella term meant to describe several different causes of shock that behave in a similar-ish, emphasis on the ish fashion. And those are septic shock, anaphylactic shock, neurogenic shock, some toxicologic shock states, and some endocrinopathies like adrenal crises. Now, just note, these do not all act identical, right? Because the pathophysiology for each of them is different, but they follow a similar pathodrome, which is why we all batch them under distributive shock. So we're talking about the pathophysiology of distributive shock. We're saying that there's pathologic vasodilation that decreases systemic vascular resistance and leads to inadequate perfusion. But beyond that, the pathophys is shock state specific. So in septic shock, you get this cytokine storm. You have an infection, your immune system goes bonkers trying to attack this infection. And all those inflammatory mediators that are released, including nitric oxide, lead to vasodilation, capillary leak, mitochondrial dysfunction, and that can all impair oxygen delivery and oxygen utilization. Whereas an anaphylactic distributive shock, this is usually IgE, immunoglobulin E mediated. Your mast cells degranulate, and you get all this IgE that leads to mast cell degranulation, and that releases histamine and leukotrienes, and that leads to vasodilation and increased capillary permeability, and you get other things like bronchospasm and swelling. So that is anaphylactic distributive shock, which behaves differently than septic distributive shock. Neurogenic distributive shock behaves even a little bit different. This is a spinal cord injury. Usually it has to be above T6, and it leads to a loss of sympathetic outflow because the sympathetic chain is injured, it's severed, so you can't get that sympathetic drive. And that leads to vasodilation. And a big difference in this is you actually get bradycardia, right? Because that heart rate cannot mobilize from sympathetic surge because you've lost your sympathetic outflow. So you get bradycardia. Whereas in the other distributive shock states, you get tachycardia. And then other causes like endocrinopathies, adrenal crises, thyroid dysfunction, toxicologic things, anesthetics, nitrates, all these are characterized by this pathologic vasodilation. So just note, we put all these under distributive shock, but you can't silo these, right? They all are different, although they're kind of married by the similar underlying pathology of pathologic vasodilation. All right, what about hemodynamics and this concept of oxygen consumption? So we've talked about shock on this channel before. Definitely check out those other episodes on shock because there's a lot more kind of introductory material on what shock is and oxygen delivery, oxygen consumption, et cetera, et cetera. We're not going to dive into that as much here, but we have a lot of good episodes on that really gets into the nitty gritty, so check those out. But for the sake of distributive shock in this episode, we're going to just talk about different parameters and what you would expect to see in distributive shock. So as we said, the MAP, the mean arterial pressure, can be normal, but most often less than 65 millimeters of mercury kind of qualifies as distributive, well, as shock in general. Cardiac output, as we said, you get pathologic vasodilation. So your cardiac output actually compensates by increasing. It goes up. You get hyperdynamic, right? Your heart rate goes up. In later stages, though, if it can't maintain, you might get lower cardiac output. But in those early stages, cardiac output definitely increases. Your systemic vascular resistance in distributive shock, hopefully this pops into your head because we've been saying it over and over again, is markedly low. This is one of the hallmarks of distributive shock. You get vasodilation, aka decreased systemic vascular resistance. Okay. Your central venous pressure, your CVP, this is something we've talked about on the channel too. Check out those episodes. Just search central venous pressure and they'll all pop up. This is going to be low or normal due to the vasodilation. Remember, distributive shock in and of itself is not a hypovolemic state, but it does often benefit from fluids because you have a relative hypovolemia from all that vasodilation. So your CVP might be low or normal, just depending on how much vasodilation there is. And then your oxygen consumption, your body actually in the early stages is hypermetabolic and hyperdynamic. It is consuming more oxygen than is typical. Now, in the later stages, when you start to have some more mitochondrial dysfunction, especially in septic shock, you might have less or an inability to extract and use oxygen, which can be a really negative indicator as a poor outcome. But in the early stages, you're certainly hypermetabolic using more oxygen. So those are some of the classical parameters you might see in distributive shock with somewhat of a focus on sepsis. So we talked a little bit about the subtypes of distributive shock, but I want to dive into it just a touch more here: septic, anaphylactic, and neurogenic. So we're going to talk about things like the onset, the trigger, the heart rate, the skin exam, respiratory rate, hemodynamics, and then first-line therapies. So in septic shock, the onset is going to be gradual, whereas in anaphylactic shock, it should be sudden. You know, you were exposed to an allergen and you have this sudden anaphylactic reaction. Whereas in septic shock, you got to get an infection as to worsen, you have to develop septic shock. In neurogenic shock, it's usually immediately after a spinal cord injury, right? So neurogenic shock, the onset's going to be after the spinal cord injury. Anaphylactic shock, the onset's going to be within minutes of exposure to the allergen. And in septic shock, it's more gradual. Okay. The trigger for septic shock is an infection. It can be bacterial. It also could be fungal. It also can be viral, right? It could be parasitic. So any infection is the trigger for septic shock. And anaphylactic shock gets triggered by an allergen, food, drugs, bug bites, et cetera, et cetera. And in neurogenic shock, the trigger is obviously trauma or an injury to the cervical spinal cord or upper thoracic spinal cord, anything to knock out that sympathetic chain. Okay. In septic and anaphylactic shock, your heart rate is tachycardic because you're trying to increase heart rate to increase that cardiac output. In neurogenic shock, you are bradycardic because you don't have that sympathetic drive because you've injured that sympathetic chain. So that's one of the big differences here is that in neurogenic shock, you are bradycardic, whereas in septic and anaphylactic shock, you're tachycardic. Your skin exam in all these shock states are going to be warm and flushed. Okay. Now, in anaphylactic shock, you also, on the skin exam, usually have urticaria or angioedema or a rash of sorts. And in neurogenic shock, you've lost your sympathetic tone, so you're often dry and not sweaty, right? Because you don't have that sympathetic drive to do that. The respiratory exam is very similar, right? You're usually tachypnic in septic, tachypnic in anaphylactic, although you also might be bronchospastic or have airway edema because this is an allergy. And in neurogenic shock, you might be tachypnic depending on how sick you are, but sometimes your respiratory exam is normal, okay? And then the hemodynamics, which this is kind of something heavily tested in septic shock and in anaphylactic shock, you have low systemic vascular resistance and an increased cardiac output. Okay, low systemic vascular resistance and an increased cardiac output. In neurogenic shock, you still have low systemic vascular resistance, right? Because vasodilation, pathologic vasodilation, is a hallmark of distributive shock. But your cardiac output might actually be low because, as we said, you cannot increase your heart rate to mobilize that increased cardiac output. So your cardiac output might be low compared to it being high in anaphylactic and septic shock. And then first line therapy for septic shock, fluid antibiotics and norepinephrine. We're going to have a dedicated video we already have a dedicated video on septic shock, so definitely check that out. In anaphylactic shock, you really want to get intramuscular epinephrine. This is absolutely critical. This is life-saving. If someone is anaphylactic, they need intramuscular epinephrine. All right. You can give them fluids, you can give them steroids and Benadryl and all these other things, but they need IM epinephrine. In neurogenic shock, vasopressors, norepinephrine, phenylephrine, address the bradycardia, all that good stuff. Again, we'll have some dedicated videos on anaphylactic and neurogenic shock that we're coming out with, and then we already have dedicated episodes on septic shock for you to check out. All right, we're getting closer to the end. So management principles, we've kind of touched on above, but we just wanted to reinforce the point. So initial resuscitation of distributive shock states usually includes some degree of fluids, right? There's lots of discussion and debate about 30 cc's per kg in septic shock, and we're just going to leave that one as is, but that is a recommendation by, the SEP1 criteria and all that kind of stuff. But usually you need at least some amount of fluids in anaphylaxis. And neurogenic's tough because that heart rate's lower. So you just want to be careful with fluids, but, probably some fluids in neurogenic shock too. So that initial resuscitation is often volume. Okay. After that, though, vasopressors are commonly needed. And norepinephrine is first line in septic shock and honestly most shock states, with the one caveat being, remember, in anaphylaxis, you need that IM epinephrine. If that doesn't work, times two, sometimes you even need to put them on an epinephrine drip. So epinephrine is the vasopressor you want in anaphylaxis. In septic shock, though, norepinephrine is first line. Vasopressin is an adjunct vasopressor. We've talked about all these vasopressors in previous episodes, so definitely check those out. And in neurogenic shock, some people like phenylephrine. Phenylephrine is an alpha-1 agonist, so it just vasoconstricts, whereas norepinephrine has alpha-1 effects, but also has beta effects. So it vasoconstricts, but also can increase contractility a little bit. But norepinephrine, again, first line in most shock states, other than anaphylaxis, which you really need epinephrine. And then there's some adjuncts that people talk about, right? Steroids and septic shock, antihistamines and steroids and anaphylaxis. Do those work is unclear. In neurogenic shock, addressing the bradycardia with atropine or pacing or sometimes low-dose epinephrine are all things to consider in terms of management principles. And we'll be doing deeper dives on all these individual shock states where we'll get into some of the nuance of the management. This is just somewhat of an overview. Obviously, targeting a MAP greater than 65 millimeters of mercury, monitor for lactate clearance, which is really just saying AKA improving tissue perfusion, whether you use lactate or some other marker like kappa refill, urine output, end organ injury improvement, all that kind of stuff. All right, there are some landmark trials. We're not going to go through any of these. We're just going to read them out so you know they exist. None of them are super relevant to this episode, although they are very relevant to the management of the different distributive shock states. So there's early goal-directed therapy by Rivers et al. In 2001, published in the New England Journal of Medicine, which then was followed by Process, Promise, and Arise in 2014 and 15, that kind of looked at early goal-directed therapy versus usual care. There's the VASST trial that looked at vasopressin. There was the SOAP2 trial that looked at dopamine versus norepinephrine, ADRENAL and APROCCHSS, which are stress-dose steroids. Again, all these are important, and we'll leave them here for your perusal, but none of them are super relevant for this episode itself. All right, should we get into some practice questions? We'll have 3 practice questions. We just, if you're watching the video, we just peeked an answer in, sorry. 3 practice questions, beginner, intermediate, advanced. The way we do these is we'll read the question, we'll read the answer options, and then we'll go right into the answer. So if you need more time to think about it, just make sure you pause the episode because we'll just dive right into the answer. So question 1, beginner. A 55-year-old man with fever, hypotension, tachycardia, and warm extremities has a lactate of 4. Which shock type is most likely? A, cardiogenic, B, hypovolemic, C, obstructive, or D, distributive? Well, you know the topic of the episode, so the answer most likely is D, distributive. So why, right? We have a patient who is hypotensive, so you're like, uh-oh, they're in shock. They have compensatory tachycardia, so you're like, okay, their heart seems to be trying to compensate. They have warm extremities, which essentially means vasodilation, aka a low SVR state. And then the kicker here is they have a fever, which usually means infection. So in this case, distributive shock makes sense, right? Because they have low SVR because their extremities are warm. They have a fever to imply infection, which could be septic. And then they're in shock with hypotension and a reflex tachycardia. All right, question number 2, intermediate. Oop, we keep previewing the answers. Apologies. A septic shock patient remains hypotensive after appropriate fluids. According to current guidelines, what is the first-line vasopressor? A, dopamine, B, norepinephrine, C, epinephrine, or D, vasopressin? The correct answer is B, norepinephrine. So in septic shock, in most shock states, norepinephrine is going to be your first-line vasopressor. Vasopressin is going to be an adjunct that can be used later. Dopamine is no longer recommended. And then epinephrine is really only first line per kind of test questions, although in the clinical arena there's lots of nuance to this, but per test questions for anaphylaxis when it comes to distributive shock. All right, last question, and then everyone can go on enjoying their day and just crushing distributive shock management. Oh, we spaced out that we put the advanced one as something based on trials, which we then brushed through. But that's okay, still good learning here. Which trial demonstrated no mortality benefit of early goal-directed therapy compared with usual care in septic shock? A, VASST, B, PROCCSS, C, SOAP2, or D, ADRENAL? The correct answer is B, PROCCSS, right? So there's 3 trials: PROCCSS, PROMISE, and ARISE. And these looked at early goal-directed therapy versus usual care. Now, the thing to note is usual care at this point was now very kind of aggressive in intervening early, because early goal-directed therapy brought such a spotlight on to septic shock management. But they did show that the kind of bundled care used in the EGDT trial, the early goal-directed therapy trial, did not seem to improve outcomes as compared to usual care, although usual care had evolved to include some of the things done in the early goal-directed therapy trial. So something to ponder, even though we didn't talk much about it in this episode. Hopefully that was helpful. This is an introductory episode of distributive shock, and we'll be diving into the nuance and the nitty-gritties in future episodes. And anyone interested in shock in general, we have a couple videos out there, a couple episodes out there on shock. We certainly have episodes on sepsis and septic shock. Definitely check that out. We also have YouTube members where you get early access to videos and some exclusive access, a Patreon page that we've been really buffing up. And then there's also a newsletter that has taken a little bit of a backstop, but we might be bringing that out more soon. So let us know what thoughts, comments, questions you have down below. And either way, stay well, keep learning. We'll see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.